people ask me all of the time, you know, can you give us the education about our hearts just like you do our legs? Because you're not going to die from your legs, you're going to die from your heart. And there's still, how many of you out there in the audience actually have ever had your heart checked? Yep, you got a scan, but still, not enough of you. Have you ever had a calcium score done? Okay. And there, he's going to go into, Dr. Doshi is going to go into a little bit more about the different scans that you need, because it's not just an ECG that is enough for you. It's not just them taking the stethoscope to your heart that is enough for you. You need to do so much more. It's not even the nuclear stress test or stress test that may be enough for you, because we had a patient who I cannot name, but who is suddenly missing from the group because he went in, got the nuclear stress test. They said, you're great, you're doing fine, your heart's healthy, go home. He died in the parking lot. Heart attack, massive heart attack. That was completely missed. And so Dr. Doshi, I want to introduce you with Chicago Vascular to not only talk about why that might be the case, but also to help you to advocate for yourself so that doesn't happen to you. Dr. Doshi.
Kim, thank you. So I'm Dr. Parag Doshi. I'm the founder and president of Chicago Cardiology Institute, and a wonderful team of doctors like Dr. Mohammed, and we have a whole team of doctors, and then we also started Chicago Vascular Clinic. I actually did work in another group, but what Kim just described is one of the reasons we started this with a passion that we should have the latest technology be started, and all doctors should have this. You should have the latest technology, but then at heart, you should be like a family doctor with that little black meat, with compassion, because you guys are the center of everything we do. We are your servants. Our job is to serve you. So we talk about heart disease. I've been doing this for 25 years, and yet this statistic I recently read and stopped me. You hear of patients dropping dead with a heart attack, right? 80% of them did not have any symptoms of problems with the heart 5 minutes before they died. You hear this all the time. So yes, there are people with bad heart and they pass away in their sleep or they have a heart attack. Such a large majority. So we have a lot of screening. I mean, women go for mammogram and we go for colonoscopy and we go for PSA. We have failed as a society, as a country, to create awareness and screening for heart disease. If you have PAD, 75 to 80% chances that you have blackmail. Even I, in fact, believe that none of my PAD patients should be treated without making sure that their heart is okay. So how do we screen? If I ask you, sir, what do you think would be the screening? How would you want to be, or any of the other, who had some of you say you are testing for the heart done, right? Who is a person who had screening for heart disease, but is not a heart patient, any of you? So what I believe for the good screening of a heart disease is not just one test. It's a lot of things together. The very first thing, let's say you walk in my office and then I have to make sure, or you're the patient. The very first thing is keeping a keen eye. What are your risk factors? You have something, your age, being a male, smoking, inactivity, obesity, or being overweight, diabetes, having PAD, having family history, or cholesterol, blood pressure. So I like to look at it. It doesn't mean that somebody who doesn't have a risk factor cannot have it. If you have a risk factors, I already am thinking that you are, in somebody that I need to screen. Then I'm going to ask you questions, and this is very important. Overwhelming majority of the people say, I'm fine. Do you have shortness of breath? No, I don't have shortness of breath. Do you get tired? No. Most of us, what we do is we don't get short of breath or tired. You know why? Because we protect ourselves. We don't do it until we get tired. So I never ask my patient that I'm short of breath while getting tired. I always ask, How far can you walk before you get, right? Then we examine if you have, whether there are other signs. We get the EKG. EKG, unfortunately, is only going to show if you really had problems, but in a large majority of patients, it may not show anything. All of you should at the minimum have something called a calcium score. So what calcium score means that if you have a plaque buildup in the blood, the plaque is not just cholesterol. It has a lot of junk in it. And it's going through some inflammation and healing, the plaque. And in that process, it affects calcium. There is no relation with your dietary calcium or blood calcium level. It is simply a marker of plaque. So there's a very simple CAT scan. Insurance doesn't pay for it. It's about $40, $50. We do it in like 5 minutes. If we put you under the CAT scan, there is no IV. And the CAT scanner specifically looks if there's a calcium deposit in your arteries. And it gives you a score, and the score can be 0. 0 means you don't have any calcium. That means chances of having plaque are very, very low. Sometimes you can have a fresh plaque with no calcium and 0 score. Otherwise, most often, especially as you get older, if you have a plaque, the calcium score may be positive, and it can be anywhere from 5 to 5,000. The more the plaque, the more the calcium. All of you must get it. Now, some of you, we also get stress test. Now, the problem with the stress test, especially in the older population or people with other issues such as PA.D, that sometimes you are not even able to walk on the treadmill, so we do chemical stress test. Now, just what Kim described, chemical stress test also, or any type of stress, nuclear stress test, does have some limitation. There is a 20-30% chance that you can miss blockages, or it can be positive and then you don't have any. So it's not like a pregnancy test that it's yes or no, right? It's not like a COVID test. We actually do a different type of chemical stress test. American Society of Nuclear Cardiology actually recommends that. You have heard of people getting PET scan for cancer. So we actually have PET scanner dedicated for stress tests. Cardiology. American Society of Nuclear Cardiology said that's a #1 choice. The limitation of that test is that because it's so expensive, not many places. Very few hospitals in Chicago has, only Rush, I think, has it. We have it, it's not even most of the university hospitals also. They have it for cancer. They don't have it for. The advantage of that stress test, it is a lot more sensitive. It actually gives you not just the traditional stress test type of nuclear scan, but it also gives you calcium score with it, and it actually calculates how much blood is going to each part of the heart. So, and it gives lot less radiation. Yeah. So, another education that I give that if you are getting a chemical stress test, ask the doctors whether you can get a PET, PET, just like whether you can get a chemical stress test for using a PET scan. That's one thing that I would teach you guys. It is the standard of care. It's not as widely available, but most of the major cities should have some facilities. We are proud to have, right? Once we get that data, or sometimes we may do something called CT angiogram. CT angiogram is where we do a special CAT scan. This is not just a calcium score. Now we inject dye in the vein, and then once the dye goes to the heart, it actually gives you a 3D reconstruction. So you actually can see the blockages. The limitation of that is that sometimes if there's too much calcium in the artery, 10% blockage can look like 90% also because the X-ray doesn't go through the calcium very well. So ultimate gold standard, and I'm not shy about recommending it somebody who has a high degree of suspicion, is going in and looking in an angiogram. When we actually go in your heart, just like the way you guys are familiar with the angiogram of the legs, we look in the heart also. The risk of procedure in well-trained, experienced doctors should be very, very low. Angiogram should be less than 1 in 1,000 chance of major complication, right? But your doctor should have experience. My partner, Dr. Muhammad, that we have done thousands of them. He takes care of my family, right? So that's a level of trust you should have in your doctor. The key thing is not only P.A.D is risk for your wounds or losing the limb. The P.A.D is also pointing it towards the risk of heart disease and stroke. So I tend to think of any of you guys have a low threshold for making your heart check in a more advanced fashion. Just getting somebody might have had an EKG, somebody might have had, oh, no, he listened to me and he said it's fine, or he got an echo. Don't be satisfied. Because especially if you have arthritis, if you have, even without anything, but especially with arthritis or vascular disease, you're not likely to stimulate your heart enough to get symptoms, right? So that's a problem. If you got a P.A.D and if you had, or neuropathy, you get arthritis, you are going to be tired and you'll stop because of that. And you'll say, oh no, I get tired. I'm not sure of breath. I don't have chest pain. In fact, chest pain, even the doctors, 95% doctors, they equate chest pain. I was one of the investigators in a major trial in terms we did for the completely 100% blocked artery. We found very, very few patients with a completely blocked arteries. I'm talking about 100% blockage in the heart have chest pain. They just feel tired, or they are short of breath, or they feel fatigued. Just don't have energy. No, I don't want to do it. So much so that the American College of Cardiology Journal had an editorial. Should fatigue be called the new engine? Do not depend on, oh no, I don't have chest pain. Definitely I'm fine. We had one lady who was saying that I just don't have energy. I don't want to walk. And the first thing I said, you need to get your heart checked. Just because you had a bypass doesn't mean the bypass will get blocked again, right? Think of P.A.D or heart or stroke as a holistic system disease. These are diseases of blood vessels. Same steak that you ate, or same cigarette you smoked, or same remote control that you held in your hand for 8 hours and not move. Those problems everywhere, right? Clear? So I would entertain as many questions as you have. By the way, when you buy new shoes, pair of new shoes, or I put a stent in your body, right? I always say that if you buy a new pair of shoes, treat your shoes like your dog. Do you know what it means? Take it walking for a mile or so. I always tell my patients when I put a stent, this stent, treat it like a dog. Take it to walk every day. Otherwise, you don't get it. Won't be.
That I know of, but I have a family history of it. So how do I get my family doctor to order the tests you just suggested to make sure that I don't have a heart issue that's brewing?
So you just once again raised my most favorite, and I mean something that I'm so passionate about, because so many of you have been told, no, you're fine, don't do anything, your cholesterol is fine, let it be. And then meanwhile your arteries are marinating in that plaque and you're building up. So the good news about what's bad about that calcium score is also good. Calcium score is not paid for by any insurance. Any of you can probably call up local hospital. For example, we actually offer in our own place, Chicago Cardiology, that I want to get a calcium scan of my arteries, $45, $50, and you can do it yourself. You don't need a doctor's prescription. You see?
So I could do it.
And then the other thing, I will just give one extra piece of advice on. So calcium score is not, it doesn't tell you how much blockage you have, right? So it is what we call statistical odds. What are the odds? So if your score is 0, with chances of you having plaque are not 0, we're very close. But we do have some patients where a plaque was fresh, so it didn't have chance to accumulate calcium. So you can have blockage occasionally. It's uncommon, but it's still the same thing. When you get the plaque, they'll tell you that if your score is 0 to 100, your chance that means low risk of high severe blockage, 100 to 400 moderate. The problem is the primary doctors and many cardiologists treat it like, oh, your score is 50, don't worry, you're fine. No, your score is 50 means you got a plaque. Look further, treat your cholesterol, treat your blood pressure, and do more, right? This is art. Just because the chances are less that you need a bypass with a score of 50 doesn't mean that occasionally you do. So that's another lesson.
Just
Absolutely.
from my experience, is if I don't take care of this, the rest doesn't happen. So you have to.
Yeah.
It's a must.
You must, and that also you brought up as a not only that you have to tell a family doctor. The other thing I also see, both doctors in new patients, there is a massive resistance about taking cholesterol medicines and treating blood. There is so much garbage on the internet about statins. There is so much about, oh no, I want the holistic way, I want the natural way, I want this. Even a borderline increase in blood pressure increases your risk of heart attack and stroke by 30 to 40%. In the same way, even a 5-10 point reduction in the blood pressure dramatically lowers your risk of heart attack and stroke. Same thing is for cholesterol. Don't take borderline elevated cholesterol as normal. There is nothing like a normal cholesterol, to be honest. It's how low can you go? It all depends on your risk factors. So don't resist doctors attempt to start blood pressure cholesterol medication. In fact, tell the doctor that I want my blood pressure in normal range. Recommendation is currently below 130 or 80. And I want my cholesterol perfect. Don't take any chances because these are silent killers, right? So there is a huge resistance in patients and doctors.
And one of the things, and you bring up a really important point in terms of, when it comes to cholesterol, and I'm curious your thoughts, because I've never talked to you about this, but one of the things that I learned when my dad was on the verge of a heart attack was that there is a difference between a basic lipid panel and an advanced lipid panel for cholesterol. And my dad's primary care doctor refused to believe that he might be at risk of a heart attack because she said his cholesterol was normal. And she told me that she would not order an ECG or a stress test because of that. His cholesterol normal. And I said, well, do you realize that more than 40% of people who suffer a heart attack have normal cholesterol in a basic lipid panel? It's not until you actually have an advanced lipid panel where you can actually understand the quality. You could have a whole bunch of large, fluffy LDL particles and you'd be fine, right? But it's those small, dense LDL particles that when they become oxidized by trans fats and free radicals, that those can eke into damaged areas of your blood vessel and push it on out. And so it's really important to ask for an advanced lipid panel, I think.
So I think, I would modify it just slightly. So you raised a great point. So when you order a total cholesterol panel, so you get 4 or 5 values. You get total cholesterol, and quite honestly, I don't pay as much attention to total cholesterol anymore because to me, it's really the components. Then there is a component called LDL or low density lipoprotein. We call it bad cholesterol, and we call it another one is called HDL or high density cholesterol. Why is it one is bad and one is good? So it's not fair. So think of LDL and HDL as like dump trucks. They're basically garbage trucks. So LDL, lousy one, the low density cholesterol, it's a garbage truck that picks up fat from the liver and then it dumps it in your arteries. That's why it's a bad one. Well, HDL or health, it's a high density, but you can remember it as a healthy, right? It's a good one. So HDL picks up plaque, picks up fat from your arteries, from your plaque, and takes it to the liver where it's broken. You understand why it's good. And there is also VLDL or very low density cholesterol that comes from the food you eat. And there is a pure fat, which is triglycerides. Now, what I do is like, if I have somebody with a high cholesterol PA.D. where I'm going to put them on statin, and I know that I need to bring their bad cholesterol, all of you, if you have PA.D. or if you have heart disease, I lower your LDL or bad cholesterol below 55 based on the current data. So in that case, I don't necessarily order fractional because I'm already going to treat them to the max. Right. Any of you, but especially my patient, if they have, oh, but the cholesterol is normal, but the patient has a family history, even if they don't have heart disease, or if they have any risk, I order this advanced lipid panel. It is called, some facilities called nuclear magnetic resonance or NMR panel, sometimes local fractionation. What it means and what just Kim explained, that all these particles, low density lipoprotein and high density lipoprotein, they can come in different sizes. And then, so what this panel tells you is what is the size distribution of this good cholesterol and bad cholesterol particles and how many. And then depending on what your doctor adds, there may be some additional test in it called apolipoprotein B, which is ApoB is actually one of the really, I can make it very complicated, but it is really the reason why we get heart attacks. And then also another oft forgotten but extremely important type of test, which is called apolipoprotein A. Lipoprotein A is especially LPA is especially a big risk factor in South Asia, but it is for anyone. An American College of Cardiology says it should be checked for everyone at least once. And we will have specific medications for that in a year or so. So you are completely right. So in other words, if you are going to be aggressively treated, then I think especially I may or may not order. But for sure, oh no, your cholesterol normal in your dad would have been a classic reason for anyone to order it.
So an interesting question that we've gotten a couple of times is, so what's the purpose of the LDL particles? If they're just dump trucks, then why do we have them? Do they have any good?
Well, so I get this, and then we are struggling to find the right answer, right? So there is some cholesterol in the cellular wall of the blood cells, right? So there is always this thing that, oh no, if you lower too much, and this is classic, you can find some online stuff and this holistic doctor, they will try to do that. Oh no, if you lower cholesterol, it would be very bad for you. You make a dementia, you make this, and then none of that has been proven. So there is no question that there is some function of it. We don't know. So far, every trial where we have lowered it to the lowest level, we have had some incremental benefit. So LDL, there is the data that if you lower it below 40, there may be more beneficial than below 55 also. So we don't know how low is too low yet. That's all I can say.
And there is safety data to, even if you bring it down to in the 20s, we have very good data, safety data that there was nothing happened to those patients with very comprehensive testing and all of that stuff. So, and if you take a newborn, they usually have an LDL in their 20 to 30. You take mammals that are hanging around and just in the wildlife, they're about the same. So I think that our LDL is high because of our lifestyle, genetics, and everything else. And those numbers that are on the chart when you get the blood test are completely artificial. So an LDL of 120 is not normal.
Oh my
in any.
goodness.
So I think it's just artificial. We don't go by it.
So great question. So we are, first of all, at any given day, doctors believe that this is the golden age of medicine. So, but at the risk of being wrong, right? We don't know what's in the future. We are in the golden age of cholesterol management. So, first thing for the managing cholesterol comes at home, avoiding unhealthy food. I'm a huge believer in plant-based food. I'm a vegan, right? Avoiding ultra-processed food, eating more whole grain fruits and vegetables, exercising to the best of your ability, or of exercising to the extent you didn't know was possible. So that's at home. Then comes in the office. In the office, currently, the standard of care is statins. And the statins also come in 2-3 generations. I mean, I rarely use the first generation, second generation, lovastatin, or occasionally we use pravastatin, but then more the high intensity statins, atorvastatin or rosuvastatin. They are shown to improve your outcomes. Now, if that does not, if that statin at the maximum dose, maximum tolerated dose, does not knock out your LDL to the lowest, then the next step is adding a medication called ezetimibe, which is not a statin, but it adds to the effect of statin. If that does not do the job, then the next step is the injectable medicine, which you give yourself injection once every 2 to 4 weeks. Repatha, Praluent, those two. And they work very well with statins, and they should be able to. In case if your insurance does not approve, or if you are one of the rare ones that does not work, there are other options. So first of all, orally, there is a drug called bempedoic acid. It's called Nexletol. It is not actually very as strong as statin. So it's typically used for statin intolerant. But if your cholesterol, if you cannot tolerate or if you didn't get the way down with the Praluent, so there is a new drug called Lacrio. You actually have to, it's still a one injection per year to do it in doctor's office or infusion center, just because that's the insurance pick, once every 6 months. So there are so many options. And this is just the beginning. Now we are actually working. There's a new exciting data that you literally take a medication RNA base, you modify the gene that makes it, and then you can pretty much get a one shot and maybe have medication every 5-10 years. But that's in the investigation phase. They already presented data about a pressure injection. A lot of you might have heard of ACE inhibitors called angiotensin receptor inhibitors. We use them all the time. They presented with data called zilebesiran, that you get one shot and it knocks out the gene that makes the angiotensin, and the blood pressure stays down with the injection every for 6 months. Yeah. So you might be looking at a future for blood pressure, cholesterol. You just give yourself a shot once every 6 to 12 months, and you're.
See, this is amazing. This is stuff you can't find out there, and it's through amazing doctors like Dr. Doshi that takes the time like this to be able to help us to educate you, on things that you may not be able to hear from even your local doctors, but can give you hope that there's something more out there, and that so many people are innovating around this and really trying to help us hopefully at some point find it. Thank you so much, Dr. Doshi. We really appreciate your time.